So nutritional will be the most common ones. And what are the pointers that if you have somebody who comes to you with the rickets for the first time, has a possibility of a non-nutritional or a refractory rickets?
Having fractures associated with rickets like condition, or someone who has a failure to thrive, then these are the conditions.
So significant failure to thrive, features of RTA like polyuria, atherosclerotic breathing. If you have a pathological fracture, you have to get worried about in that scenario. Now, what are the common causes of non-nutritional rickets / refractory rickets, Vibha?
Rickets. Another would be the RTA.
So renal tubular acidosis, hypophosphatemic rickets. And the most common would be renal failure. So that is something, of course, you will do it in the initial phase. So we'll try to go forward on that. So rickets seems to be a reasonably simple condition to evaluate, but often we have got confusions which go off. So we had this 3-year-old boy who was referred to us in which of quote unquote a diagnosis of refractory rickets, had been given vitamin D 60,000 international units and complained of bone pain and a high alkaline phosphatase. And based upon these findings, the clinical team thought that this could be a possibility of a refractory rickets. But as we will discuss subsequently, that we do have some physiological responses to vitamin D, which include an increase in bone pain and an increase in alkaline phosphatase, which do not indicate a refractory rickets. And what we need to look at is the line of healing which was present in this case. So while this case was unnecessarily being advised, a lot of investigation in the form of a blood gas, calcitriol level and PTH, they were not required. So what we need to understand is that there are certain scenarios in which you will respond in a way and you don't need to work up extensively from that regard. So this is a normal response for rickets. On the contrary, we have this 14-year-old boy who presented to us with lower limb abnormalities predominantly and had been given huge amounts of vitamin D, and there was no line of healing. He was again referred as quote unquote nutritional rickets. So in the first case, we were making physiology into pathology. Here, a pathology was turned out to be in a physiological cause, and this unfortunately resulted in the development of nephrocalcinosis. If you have a late onset rickets with predominant lower limb abnormalities with a normal PTH, normal calcium, think of hypophosphatemic rickets. So when we talk about rickets, we have to balance between the not doing too much workup where it is not required, while not missing on pathological cases. So this missing and messing is something which we want to avoid. Rickets overall is a reasonably common condition, usually nutritional, but refractory rickets may pose challenge, as we saw in the second case in that perspective. All of you can go and have a look at our website, learning.growsociety.in, which has got a lot of information about pediatric endocrinology, including resources and courses. Our e-learning portal on YouTube, which has got a lot of videos on pediatric endocrinology. Our validated courses, which provide information, including fellowship course and postgraduate courses as well. And our regular programs in the form of grand rounds, journal clubs, and PG lecture series as well. We've got publications across board from protocols to advanced in basic pediatric endocrinology and mobile applications which guide assessment. Now, coming on to the management part, I think we already discussed about the nutritional rickets. For the otherwise, the treatment is quite simple. For distal RTA, you give bicarbonate and you give supplemental vitamin D. Proximal RTA, the bicarbonate requirements are very high along with phosphorus. VDDR1, you require high dose calcitriol and calcium. And VDDR2, you need very, very high dose of calcitriol, and hypophosphatemic rickets is a complicated scenario. So we'll discuss a bit of it. So distal RTA, once you give bicarbonate, the usual dose initially may be high, but then you need 1 to 2 millimoles per kg per day. And this will result in resolution of acidosis and your potassium levels will improve. So they have hypokalemia, which improves with treatment. For proximal RTA, you need much higher doses of bicarbonate, and this results in a load of sodium, resulting in a potassium loss, causing worsening of hypokalemia. So you have to give them enough amount of potassium as a supplement, and also phosphorus, and sometimes thiazide diuretics may be required. For hypophosphatemic rickets, what you have to do is to give phosphorus around 30 to 50 milligram per kg per day. Do not give too much phosphorus at a time. If you give more phosphorus at a time, PTH will get up, and it will remove in the urine. Now, whenever you do that, you will also need to give calcitriol because there is also a deficiency of calcitriol which happens in the setting of this scenario. And if you have hypocalcemia, you will have hyperparathyroidism, which is going to cause a lot of problems. Phosphorus will come down, and you will also have a problem of tertiary hyperparathyroidism, which may evolve over time. So you don't want to give too much. In this case, you can give calcitriol, and you can also give a calcimimetic like cinacalcet, which can also suppress the parathyroid level in this perspective. If you give, however, too much calcitriol, there's a risk of nephrocalcinosis, which you need to be bothered about. Use thiazide diuretics as required. The most specific and the most promising therapy is the monoclonal antibody against FGF23, which is available as an injectable burosumab, which is quite helpful and causes a physiological response in the setting of hypophosphatemic rickets, and that's something which is important. Very importantly, do not miss the hypercalciuric variant. In this scenario, you do not need to give calcitriol. In this perspective, this is the NP22 variants. So you have to give phosphorus at around 40 milligram per kg per dose in divided dosage. Calcitriol, again, vary in terms of the various responses. You can also use alpha calcidiol if there is no renal dysfunction. And phosphorus, there are various preparations available. The neutral phosphorus preparations in the form of sachets are quite helpful. Alternatively, you can make your own phosphorus in the form of inorganic phosphorus, which is there. The key things to look at are growth, which should be normal. Phosphorus levels, don't worry if they are low, because often you will not be able to achieve a very high level of phosphorus anyways. ALP should be targeted at a high normal level. If your ALP is high, you increase the phosphorus dose. If your PTH is high, that is 2 to 3 times above the upper limit, you increase calcitriol. If despite adequate doses of calcitriol and normal calcium, it is not coming down, this may be emerging towards a tertiary hyperparathyroidism. You can think of cinacalcet as a calcimimetic in that regards. Monitor hypercalciuria to avoid nephrocalcinosis, and annual ultrasound will be required in this scenario, and look for X-ray for response. You have to be very cautious. So hypophosphatemic rickets requires a lot of evaluation in terms of management and follow-up. So we have a child with hypophosphatemic rickets on phosphorus 40, calcitriol 30. Phosphorus is 2, PTH is 200. What will you do here, Dhwani?
Phosphorus is usually around this range for hypophosphatemia.
Yes.
Expected to flow normal, but because PTH is high,
so we can push the calcitriol dose a bit and reduce phosphorus also, because you don't worry about this phosphorus level, because you're giving too much phosphorus and you're getting less calcitriol. After 2 years, phosphorus was 30, calcitriol was 25, now has polyuria and abdominal pain. So there is hypercalciuria and renal calcification. So you have to definitely think of reducing the dose, adding thiazide, which is also going to help in that regards. VDDR management is a bit challenging. For 25 hydroxylase, you give calcium and you will have a response. For a problem in VDDR 1A, you would need to give a high dose of calcitriol to begin with, because the initial phase for healing, you need high calcitriol and then you come down. The dose is 150 to 200 nanogram per kg per day, which is roughly 6 to 8 times the normal dose. Now, why are we doing that? Remember, when we talked about the IAP guideline, they are saying 600 for maintenance and 3000 for treatment. So 5 times. Same here, 25 to 50 is the normal dose, but you need to give 150 to 200. So you need an initially high dose of vitamin D in that regards. 24 hydroxylase you can manage with vitamin D. VDDR2 is a nightmare. You need a huge amount of calcitriol, which is required, and some patients may require IV calcium. You to have a look at our website, at our various courses, our publications, our learning portal, as well as the mobile application.